some cases to discuss. My conflict of interests are shown here. I am going to talk about some of the things that are on that slide, companies like Astute Medical, Biomarkers, Baxter. You're laughing. My philosophy is to take money from as many different companies as possible, therefore I can't possibly... No, I'm actually quite gratified by the fact that in recent years, a lot of companies have actually been interested in this space. And, many of us, Claudio, Ronaldo, myself, we went around with our hat in our hand, and we couldn't find companies willing to fund trials in this space. And obviously that's really changed a lot recently, which I'm quite happy to see. So the first case that I'm going to talk about is a 68-year-old female that I took care of a few months ago in the cardiothoracic ICU. And she was post-operative day 4 after mitral valve repair. And she was readmitted to the ICU with respiratory distress and was reintubated. Her chest x-ray showed bilateral pulmonary edema with bibasilar infiltrates, more on the right than the left, and a bronchoalveolar lavage was sent when she reached the ICU. She had a fever, both on the floor and persisting in the ICU, of 38.9. She had an increased white count, and all of this sort of began about 24 hours earlier on postoperative day 3. She had been started on cefepime and vancomycin somewhere between the early onset of the fever and the admission to the ICU, maybe a few hours before the ICU admission. She had a serum creatinine of 1.1 at baseline, that's milligrams per deciliter. It went to 1.3 on postoperative day 4, but by postoperative day 5, it was 1.7. That was sort of the next morning that I was sort of seeing the patient admitted to the ICU. Her urine output was about 20 cc's per hour, however, and her fluid balance since the OR 4 days earlier was 6.2 liters.
Are you going to tell us about the echo findings, or no?
Yeah, so we could. Yeah, so I didn't put it in the slide.
Okay,
of course, she got an echo.
Sure, of course,
because you can't get readmitted to the CTICU without an echo.
Yeah.
And her echo showed RV was a little juicy, but LV was working fine. And there was no particular
mitral valve
and the mitral valve, more importantly, was
fine.
pristine. There was no problem.
And the left ventricle looked okay.
With the mitral valve.
And the left ventricle was not dysfunctional.
Correct. Correct. And of course, this is the pathophysiology of AKI as it relates to sepsis and surgery. And this is the pathophysiology of AKI as to how most of us manage it, right? This is sort of salt water, right? So this is sort of what we see in North America. I know it's much more nuanced in Europe. We use balanced fluids more, but in general, this is kind of what we do in the ICU, right? Every reason is a reason to give a fluid bolus. It reminds me of a list that I've seen somewhere else with only slightly better results. And of course, there's evidence that fluid boluses can be harmful in sepsis, right? So this is a study that I don't think it's gotten enough press, actually. This is a study that Catherine Maitland did in Africa, and in children with sepsis. About 2/3 of the patients had malaria, but there were other forms of sepsis as well. And the boluses were actually, which is the two curves at the top with the highest mortality, whether it was albumin or saline, both had a increased risk of death compared to no boluses. Now, the no bolus group still got fluid, but they didn't get fluid boluses in a population that sort of everyone thought would clearly benefit from increased fluids. When we did the early goal-directed therapy study, this is the PROCESS trial, one of the 3 big trials that was published a couple years ago on comparing early goal-directed therapy to standard of care. Ours was a little bit different in North America. We had 3 arms. We had what we called a protocolized standard therapy, which actually gave the most fluid, compared to early goal-directed therapy, which gave more fluid than the usual care. And as you well know, there was no signal in terms of mortality. However, there was actually a trend toward worse cardiovascular outcomes in the group that got the most fluid. I mean, there's a p-value of 0.06. Doesn't suggest that more fluids to prevent cardiovascular compromise are beneficial.
Can I get to interject?
Yeah.
So, no,
Please.
3 days ago, the
Yeah.
American Journal of Respiratory and Critical Care Medicine published a study by John Fraser's group in ovine endotoxemia showing that if you give a bolus of fluid, vasopressors go up big time. So I'm sure you've seen it or you've heard it.
It's very interesting.
So
And
it's
of
very
course-
nice mechanistic study.
Yeah,
with
and of
all
course
the
you've
limitations.
done some work. I don't think it's published yet,
Yeah, sure.
but on fluid boluses as well, and the intermittent. There's a whole story. So
Yeah.
I imagine next year Ronaldo will have an entire presentation on the effect of fluid boluses on the renal circulation. It's fascinating the effect that this has. But the signal was statistically significant for the primary renal endpoint. Of course, we took this directly from the early goal-directed therapy trial that Manny Rivers published a decade earlier, which was the rate of new renal replacement therapy. And it was statistically significantly higher in the patients that received the most fluid, which is really quite interesting. Now, to be fair, as it shows at the bottom of that screen, I looked at every other conceivable definition of AKI, either by biomarkers, by KDIGO, by different time points for dialysis, and I couldn't find a signal. But there was no benefit either. So there was no harm in other endpoints other than the one that was primary, but there was no benefit either. So it's clearly not the case that left to our own devices, we give a certain amount of fluid, and if we protocolize the therapy to give even more fluid, that doesn't appear to be beneficial to any endpoint that we can find. However, if we tell people to give less fluid, as Ronaldo just showed you, that also seems to be a signal as well. And I put this slide up. You just saw it from Ronaldo. This is from the paper, which I think has the order reversed relative to Ronaldo's presentation. So restrictive fluid is now on the left compared to liberal. And you can see, I just want to emphasize again, that the mean fluid balance was about 3 liters. It maybe was even less because, as was pointed out by the gentleman's question, that in fact the weight gain was about a kilo and a half. So there should have really been about a liter and a half of fluid balance that was positive, not the 6 liters that our patient has, and Ronaldo's already well pointed out this signal. Of course, our wonder is whether the type of fluid may have mattered, and if you're not familiar with these trials, just to show you these 2 trials in the New England Journal, both in high-risk patients shown in the left lower corner, and low-risk patients, there's about a 1% absolute increase in the risk of major adverse kidney events at 30 days. And, this NBC News called me about this. I wasn't an author, but they called me about this, and they said, why do people in North America give saline? And I said, I don't know. I said, I don't know. And it's fascinating because the veterinarians in our country don't give saline. My dog got sick. Actually, my dog developed sepsis-induced AKI. Can you imagine? What are the chances?
So cool.
And the dog was a very old dog, had terrible dentition, and they developed sepsis from that source. And the dog was ancient, so we didn't want to do anything, but unfortunately we were on vacation, and the dog sitter just couldn't possibly make the dog comfort measures only. So the dog was brought to the hospital, whereupon the dog was treated. And I talked to the veterinarian, and she said, yeah, we gave it a bit of fluid. I said, what kind of fluid did you give? She said, Plasma-Lyte. They don't give saline. And yet, human doctors in North America, at least until these studies, gave saline. But NBC News calculated the total number of patients this could, because of course saline is the thing that every single patient gets, or fluid is the thing that every single patient gets when they come to the hospital. And there's about 50 to 70,000 fewer deaths if we would avoid saline potentially. The reason I bring all that up is that in this case, I really had to restrain the surgical resident not to give more fluid to this patient. The surgical resident's brainstem reflex was low urine output means fluid, and the only thing he thought, at all a modifier of that, was he wanted to know what the echo showed, right? Because if the echo had showed that the mitral valve was falling apart, or that the LV was dead, then he would have agreed that there's no fluid. But in the absence of a cardiac dysfunction, to the surgical resident who was weeks from graduating to be a surgical attending, it was clear that the only thing you need to do with these patients is give yet more. And even when I showed them the patient was 6 liters positive, not 2 or 3 liters positive, not 1.6 weight gain positive, but 6 liters positive, I had to restrain the resident to get the care that the patient ultimately. Fortunately, it was during the day, and the surgeon was actually more interested in going to the OR. So even though he didn't agree with me, he decided that he's too late for his next case, and so he was kind of going to shout a few verbal orders, which we ignored, and then run off to the next case. Whereupon I gave the patient Lasix. She had a good response and ultimately did okay. However, the creatinine did continue to go up, which got me into another conversation with the resident's boss the next morning about why I gave the Lasix, but ultimately did okay. We also stopped the vancomycin because the BAL showed gram negatives and was probably the source of the AKI with sepsis and some white blood cells. Comments about any of that? Ronaldo, would you have done anything differently? Do you have surgeons that I've been to your ICU, so I know what the...
No, it's the same. No, I think we have similar problems, and in our environment, many cardiac surgeons really hate giving vasopressor drugs. And so when you have a patient who's hypotensive, as she may have been... And
she wasn't. I should have pointed out, she actually wasn't hypotensive. The only indication in the surgeon's mind for volume was low urine output. And when I explained that the low urine output was due to AKI, it just didn't seem to register.
Mm-hmm. Yeah. So no, we have similar problems. And the difficulty, of course, is that... surgeons, as you well know, as we say in Australia, sometimes right, sometimes wrong, always certain.
Always certain. Yeah. That's exactly right. That's exactly right. Well, we don't want to if there are any surgeons in the audience, they want to take us to task for this. I don't do what they do, so it's easy to criticize.
Of course. No, they do amazing things.
Of course, they don't do what I do, so that's why I criticize. But,
yes, of course, yeah.
Questions, comments on this case? What's the prognosis in this case, and what should I do with this patient? We don't talk about this at all, right? Because as intensive care docs, which I am, we just oh, you made it out of the ICU. Good luck. Have a nice life. We assume that these patients do well. What is the risk? It turns out that it matters a lot of what the etiology of the AKI, and you saw that today. You saw a presentation by Dr. Sain that showed that clearly. Even full recovery after cardiac surgical associated AKI is not as good as not having AKI at all. But this was not exactly cardiac. This was 4 days post-op. Sepsis this is probably more septic AKI. And you also saw from Michael's presentation, from Hernando's presentation, I think it was my data, but from Hernando's presentation, that in fact sepsis looks a little different. In fact, he showed you this slide, which is the recovery. And you can see that patients that recover from acute kidney injury, from sepsis, seem to do pretty well, at least for the first year. Now we have some data following them out even longer, and they seem like they're okay for about 3 years, but some people have published some data out 10 years and suggesting that might be a problem. But in any case, this patient had stage 2 AKI, and I really thought that it was important that the patient be followed. And so I suggested to the patient, in fact, I consulted nephrology on the way out the door, and they said, why are you consulting me? I said, because I want the patient to be seen in follow-up. Can you make sure they know where your clinic is? That's the whole reason. Thoughts, comments about any of that? Yes, question here, and I think I saw a question here. So we have two comments or questions. One here and then one here.
I would give Lasix to this patient, but what would be your comments if someone in the audience started dialysis on that patient?
Yeah, it's a very good question. In fact, I didn't think the patient would respond to the low-dose Lasix, and then you're left with a decision: do you push the Lasix higher? Do you add additional drug? And I have to say, I have gone back and forth in my thinking about this quite a lot. So I would say probably 15 years ago, I would have pushed the diuretics to a very high dose before I considered renal replacement therapy. I would say 5 years ago, I would have gone straight to renal replacement therapy after a patient like this not responding to a low dose, a reasonable dose, a 40 of Lasix, maybe higher if the patient had been on Lasix previously or been older. But I would have gone right to CRRT. I'm now kind of back again to pushing the diuretics a bit more. And of course, as the second case that I'm going to show you in a second bears out, I'm using biomarkers to help me make that decision. And so somebody with a really high biomarker level is just not going to do well with diuretics. And so I'm pushing more toward renal replacement therapy. But I'm not so convinced. I mean, in a certain population, cardiac surgery associated AKI, which again, this is not exactly, early renal replacement therapy may be a good move, and that's what Alex Arbach's study showed. But in medical ICU patients, and this patient at this point with the pneumonia is more like a medical ICU patient, the Gaudry study, the Akiki study, really doesn't support the idea of doing early renal replacement therapy. So I'm a bit more hesitant, and I'll try diuretics first. I don't know, Ronaldo, I'm sure you have an idea.
Yeah, I agree with you. I was wondering about the dose of diuretics where you do the diagnostic test a la Ming Chola, where you actually go 1 milligram per kilo and see if the response, because, that's a kind of like a biomarker-like intervention. We'd like to comment on that.
Yeah, I think it's, if you try to do it was a 1
milligram per kilo.
Kilo, you wind up giving somewhere between 60 and 120, which isn't much more than the 40 that I gave. So yeah, you could have given 80 instead of 40 in this case and be done with it. Because if they don't respond to the 80, which, if I'm assuming that the patient weighs about 80 kilos, which is kind of a typical Pittsburgher, I think, and maybe a bit less. This was a small lady, as I recall. If they don't respond to that, then chances are good that they're just not going to be diuretic responsive. And continuing to give diuretics in the face of lack of response is probably a definition of insanity. So that's how I would answer that. Question over here, yes. Right over here. Raise your hand so the microphone can reach you. It's on its way. Yeah.
And then Claudio wants to.
And Claudio has a comment as well.
Do you want to?
Yeah, I guess. It's his meeting. Yeah.
George Alvarez from Calgary, Alberta. 2 comments and a question, and the question becomes a plea. So, number 1, I don't think there's anything normal about normal saline. So I agree. Number 2, Canada is slightly less litigious than the States, but I would caution people that gentamicin-associated ototoxicity is still the most successful lawsuit in North America. So if it doesn't work with 1 mil per kilo...
I was being funny.
So I wouldn't go again. But I don't know what other people would do. And I guess my question is, I'm trying to convince my department to get a nephrologist ICU follow-up clinic. I have a physiatrist that sees them for their critical care neuromyopathy. I have one to see them for their ARDS 1 year out, but I can't convince anyone to get a nephrologist so I can see them 6, 12 months out. In Australia, New Zealand, in the States, what do you think about that? Creating a clinic specifically for that?
It's absolutely essential. I presented a case last year at this meeting, which I only discovered because, if you can bring the microphone down front for Professor Ronco.
Professor Ronco,
I presented a case last year, broke my heart. I only found out about this case because we were doing follow-up for our research project. And on the consent form, it says, if you have any questions, call and she called me. And I started talking, and it was a young patient, who developed sepsis, severe AKI, CRRT, in the wake of all this, lost her husband, lost her life insurance, lost her medical insurance. She lost everything, really. And she had recovered completely kidney function by discharge. But at follow-up, she had clear evidence of chronic kidney disease, as well as unmanaged diabetes and hypertension. And I managed to get her all plugged in, but I never even found out about this case, and wouldn't have, nor would she have, quite frankly, if she hadn't been part of the project. So I think these patients are out there, and I really think that that's an unmet need. The follow-up for post many forms of critical illness, but AKI in particular, I think is, so I agree with you 100%.
I just want to comment
Oh,
as
yes.
well. This is clearly a research priority. So I've got a PhD nephrologist. The nephrologist doing a PhD with me, and we are planning a multi-center phase 2 randomized control trial. And we're working with the George Institute in Sydney, who have an office in Beijing, and we are planning also a phase 2 randomized control trial combining Australian and Chinese population to see if randomizing patients to nephrology follow-up with a structured sets of interventions. You know, if you've got blood pressure, this is what we will do, and this is how we'll follow up. If you've got proteinuria, this is what we will do. If you've got diabetes, we will start one of the flozins or the gliptins, and that's what we're going to do now. All of that kind of stuff. So it isn't just we refer them to you, but there are, in the Australian environment, 6 steps, and the Chinese 8 steps, because 8 is good luck, so that they have to do them. And we'll see if it brings about a change in the trajectory of renal dysfunction after AKI. It's a potentially a massive issue of public health.
Yeah, agreed.
Claudia.
Yeah, this concept that AKI is a doorway to chronic kidney disease is not new to the nephrologist. I think in Italy we have a good model for one reason. When the primary doctor see a patient with 1.3 creatinine, he immediately refers this to a nephrologist. So when patients are discharged from the ICU, if they still have abnormal serum creatinine, you can be sure that within 6 months, that patient is going to be seen by a nephrologist. And I think this is very important. The other issue is that we still have to convince the nephrologists themselves that this is a patient to be followed. But even though you have a normal serum creatinine and you have baseline GFR, which is normal, we have clearly demonstrated, and Fike is the first author of this paper, that they might have lost a significant amount of nephrons losing renal functional reserve. So if these patients are followed by a nephrologist, they might actually require to have a test for renal functional reserve. And if they lost renal functional reserve, their outcome in the long term is going to be bad because these patients have initiated the slippery slope of the chronic kidney disease. So I think it's a very open issue, but this would require, a certain amount of money, especially in a fee-for-service environment, to allocate resources to get people seen by the nephrologist. And there is a claim in many countries that there are not enough nephrologists and so on. No, the other issue was about the fact that you are more cautious about beginning renal replacement therapy, and I think we all are, because indeed we are going towards a less invasive ventilation, a less invasive hemodynamic monitoring, so probably we're going through a process of being less invasive with renal replacement therapy. However, in the past, those patients were dying because of complication of acute kidney injury, like GI bleeding, for example. And the only way to treat them was to dialyze them and to avoid the complication of AKI. Today, this complication can be taken care a little bit better without dialyzing the patient. So we have slightly modified the entire clinical picture of AKI, and we still might think to treat some patient conservatively, monitoring any type of possible complication that we have in this patient. So I think it's a good idea. It's an appropriate approach. Still, however, although you may be more cautious, you don't want to get a frank uremic syndrome to develop. You don't want to have a patient who really...
The way I sort of look at it is that the pendulum swings, but hopefully the excursions get narrower as we home
in the middle.
As we home to something that's actually probably better calibrated. And so I certainly don't practice the way some of my colleagues, and they don't practice this way either, 10, 15 years ago, where they really let patients, I mean, we couldn't enroll patients in trials in some places because one of the exclusions was a BUN greater than 100. And we just don't see those patients anymore.
But let me make a little provocative statement. Those who wanted a number to decide when to start were mostly the Americans that wanted early or late based on a number. In Europe, we were a little more clinically oriented towards the criteria of precision medicine, if you want to use a modern term. So I think that you have to judge patient by patient.
Yeah. So that's a good segue into this last case that I'll just go over very quickly, and I'll get through it, and then we'll have some conversation at the end. I want to introduce the concept of kidney stress, okay, which is a new concept. Kidney stress refers to a non-lethal cellular injury or noxious stimuli. It may be a protective response pattern or downregulation of non-vital cell functions. And you've heard a little bit of that in some of the presentations already today. And these cell cycle arrest markers are often referred to as kidney stress markers. And the reason for that is that they seem to go up with even just noxious stimuli that don't actually cause injury. So let me tell you a little bit about these markers. They were discovered using a discovery validation framework. Many of you have seen this. Hopefully all of you have seen this previously. But in case you haven't, this was a big multi-center study where we did a validation, a discovery and a validation stage. And we found sort of the usual suspects, as Michael Janides might say, along the coming up from the bottom there. And then at the top, there were these two markers, tissue inhibitor metalloproteases 2 and insulin-like growth factor binding protein 7, these cell cycle arrest markers, which were better than any of the existing tests for detecting acute kidney injury. The reason I say that they're stress markers is that, and this is a complicated slide, in the interest of time, I'll just point out the lower right-hand panel is LDH. And on the x-axis is control nutrient deprivation. This is in isolated cells. These are primary proximal and distal tubule epithelial cells, human. And they're exposed to nutrient deprivation and then oxygen and nutrient deprivation and then reperfusion. And the idea is to sort of simulate an ischemia reperfusion in a single cell environment. And what you see here is LDH, which is kind of a classic measure of cell death. And you see with nutrient deprivation alone, you don't see any cell death. You do with a full ischemia reperfusion. But just with the noxious stimuli of nutrient deprivation, just making the cells unhappy, you get a burst of IGF-BP7 and a burst of TIMP2. So it doesn't require cell death, and it's all gone by 24 hours. Equally, Alex Zarbach did a study that I helped with a little bit in terms of the biomarkers, and what he showed was that in remote ischemic preconditioning, you also get this signal, this increase in IGF-BP7, TIMP2, just from remote ischemic preconditioning. This does not cause AKI, but it makes the biomarkers go up, and actually subsequently there's protection, which has been not shown in some other studies that haven't actually measured the biomarkers or selected patients the same way. But just to show you that this is very different from the NGAL signal, you see no effect of remote ischemic preconditioning, a noxious stimuli that's not injurious. It doesn't raise NGAL, but it raises the. And Peter Pickers, who's in the audience, we did a study. He did a study where we measured TIMP2 for him and IGF-BP7 and showed that actually NephroCheck goes up with LPS stimulation at a sublethal, subinjurious, healthy volunteer kind of dose. And so this noxious stimuli is what's driving the increase. Of course, having the cells under stress, the kidney under stress, allows you to say, oh, okay, if the kidney is under stress, is there something I can do? And that leads to this case that I took care of recently, a 56-year-old female who had one of Mitch Rosner's type patients, cancer patient who had a uterine tumor that perforated, and she developed peritonitis. And she was treated with vanco, cefepime, Flagyl, and caspofungins. Her culture ultimately growed some candida, although it wasn't too impressive. She had some staph on some cultures, but not on others, and so she was on all these drugs. White blood cell count had been elevated, lactate elevated. She was on norepinephrine for 3 days, mechanical ventilation for a week. You get the impression. She's sick in the ICU. And throughout all of that, her kidney function remained perfectly stable. Nephrons of steel, okay? No problem at all. And then I came on the scene, and she said, oh, you're an AKI specialist. I must have to have AKI to get your attention. And she she developed a rise in her serum creatinine. And it was just strange. You know, she'd had all this sepsis, and the creatinine was totally stable, and now the AKI is developing. And I couldn't understand what was going on. And we did some usual stuff. We got a CT scan because she, of course, had to get a CT scan. She had abdominal surgery, pelvic surgery. Some liver function tests were mildly elevated, but nothing to get excited about. And the creatinine just kept going up. And even though it's not really what we use NephroCheck for, we use NephroCheck to predict what was ultimately happening here, I just sort of wondered, is this kidney under stress? And it's like, and her white count was normal, and no bands, lactate was normal, and man, was it under stress. Okay, and I said, I know the cause. It's the vancomycin. We'll just stop the vancomycin. And of course, and this data has been presented, I think, or slightly different version of it's been presented already today, but this is a paper that Marlies Osterman published with us just recently showing this very nice kinetic around vancomycin exposure in patients who develop AKI. And I said, okay, that's what this is. If I stop the vancomycin, the AKI will go away. And I had to actually show the NephroCheck value to the oncologist to get them to agree to stop the vancomycin, because in their mind, this is a patient who's, has ongoing sepsis. Even though the white count's normal and it doesn't appear to be anything going on with this patient, I had to convince them to stop the vanco. And they did. They were convinced, but the creatinine kept going up. And in fact, I got another NephroCheck a few days later, and the kidney's still under stress. And the patient ultimately ends up on CRRT, and I couldn't understand what was going on with this patient. And then finally, a few days later, of course, the creatinine comes down once you start the CRRT, but that's not kidney recovery. It wasn't making much urine, still the creatinine is low. And so finally, we got another set of LFTs, and they're off the charts, or at least they're quite significantly elevated. Abdomen exam was completely benign, but the patient was a bit delirious, and it's not exactly clear. So we got a right upper quadrant ultrasound, and it showed that she's got this thick, ugly-looking gallbladder. And so we put a perc drain in, the surgeons put a percutaneous drain in, and the liver function all came down, and the NephroCheck resolved, and ultimately she recovered. And so to me, the lesson here is that what kidney stress is telling you is that there's something going on. It might be that you've already figured it out, and then the kidney stress should go away. But if there's ongoing kidney stress, to me, that's telling you that there's something that you've got to find. And in this particular case, it was a total red herring. No one would have guessed this patient had, a gallbladder that was hot after all of that she'd been through, and that we just needed to drain the gallbladder. So this was a huge surprise, very unusual case, but it gives you some sense of what I think the stress variable is sort of telling you in these patients. And I think given that, I will thank you. Maybe I'll give Ronaldo the last word. Comments?
No,
no
that's
comments?
no. And
I'll thank you for your attention and move to the next talk.